Good evening, everyone. Thank you very much for joining us on this Friday evening in the brisk winter that has now joined us. And I'd like to welcome you all to this evening's talk about pre-implantation genetic testing for aneuploidy. My name is Dr. Suvir Venkataraman. I'm the manager at Harley Street Fertility Clinic. And first, I'd like to introduce this evening's panels. So on the panel this evening, we have the director of the clinic, Dr. Geetha Venkat. And I do have to make apologies for Miss Sam Knight, who's our lab manager. She helped me with these slides, so I'd like to acknowledge her for that. And then last but not least, we also have Carina Nobrega joining us, and she's one of our patient coordinators, so I'm sure you'll all be in touch with her if you haven't been already. So this evening's agenda. So we're going to discuss pre-implantation genetic testing, but we also want to first show you where it fits in the picture. So we're going to talk about what's required to have a healthy baby, which is what everyone really wants, and the potential hurdles in getting there. And that's going to be covered by Dr. Geetha Venkat. And then I'll speak about choosing the best embryo. And then last but not least, again, Carina will discuss the practical steps. So, what does this actually look like for anyone who wants to embark on this journey? So without further ado, I'd like to hand over to Dr. Venkat to talk about the first part.
Hello, good evening, ladies and gentlemen. Welcome to this webinar. When people come to fertility clinic, all of them want to have a baby, but we must always think about having a healthy baby, because if you have unhealthy embryos, like embryos with chromosomal abnormalities, one can have problem that embryo will not implant, or even if one gets pregnant, it will end up in a miscarriage, which is more traumatic. I know we feel that we got pregnant, but however, miscarriages are like bereavement, it's more traumatic, and therefore it's important to say we would like to have a healthy baby. So what do we need for that, to have a healthy baby? We all know that to make a baby, we need sperm and egg, which should be healthy, and then when they are fertilized, they become embryos. And this embryo is deposited in the uterus, which is the implanting bed for the embryos. And that is the receptive organ. And there should not be any other issues interfering with implantation. So these are the basic things required for making a baby. Now, what could go wrong, or what are the possible risks? Yes, we fertilize the egg and the sperm in IVF in the laboratory. Then we put the embryo inside, but the embryo may not implant. It may be due to the problem with the embryo or problem of implantation. Next one is, like I said before, if the embryo is chromosomally abnormal, even if it somehow implants, this pregnancy will end in a miscarriage. Or if the pregnancy continues, then it can lead to stillbirth, baby dying before the full term. Or in other cases, these chromosomal abnormalities can lead to, we call it congenital abnormalities or birth defects in the baby. Who wants all these things? We want to have this sperm and egg fertilized, creating an embryo, and the embryo is deposited in the uterus, ending in a healthy baby. That's what we are here for. That's what is going to make you happy in your life. Right. So now, what are the possible complications or hurdles in this process? What could go wrong, which will prevent you from having a healthy baby? And first of all, we start with the egg on one side and sperm on the other side. From the egg, we can say that, look, if the egg number is low, that's called low ovarian reserve. It also goes along with the poor quality of eggs. And as one gets older, the egg quality deteriorates, and that can be associated with chromosomal abnormalities. And what we do is then we assess the egg quality, and that's how we come to know whether it's a good egg or not so good egg. And we also assess the egg quality and egg number by hormone profiles as well as with ultrasound scan. You might be thinking how we can assess the egg in the ultrasound scan. We do not assess the quality of the egg, but we assess the number of the eggs by performing an ultrasound scan. How we assess it, we see antral follicle, little follicles that is, these are immature follicles in the ovarian cortex, which we can count, which will give us the total number of eggs for that month. And then the actual quality is assessed only by IVF treatment at the time of the egg collection by the embryologist who is looking at the eggs. And the experienced embryologists are so good, by looking at the egg, they will say, this is a good egg. Or they will say, no, the egg is full of vacuoles and granules. It doesn't look good. So they will be able to assess the quality. But at the end, of course, we come to know about it when the fertilization happens, and the next day when the embryologist assess the fertilization score. Next point is the sperm. Like I said, egg is on the one side and the sperm is on the other side. How do we assess the sperm? It's the basic semen analysis. That is the reason we say we should not forget the man when we are investigating the couple. Everything is focused on the woman, but then nobody talks about the man. So the man doesn't need big tests. He needs the semen analysis. Of course, some of them find it so difficult, especially producing sample in a clinical atmosphere. They hate it, but somehow it has got to be done. But in this time, COVID time, in our clinic, because people are not allowed to travel unnecessarily, we do have a home sperm test kit, and we can send it to you by post. Or when your partner comes to the clinic for an ultrasound scan and blood test, she can collect it for you, and the test can be performed at home, which will give you the basic count as well as the motility of the sperm. That is good enough for assessing whether the sperm is good for natural fertilization or not. And if there is, in complicated cases, or if there is some issue with the semen analysis, we do what is called the sperm DNA fragmentation. This will tell us how much of the DNA in the sperm is fragmented, and there is an index for that. Based on that index, we can say whether it is possible for someone to get pregnant naturally, or they need IVF or ICSI treatment. Now we move on to the embryo. So once the egg and the sperm is fertilized, that becomes an embryo. Here there is mixture of the sperm and the egg material. That's why the quality of the egg as well as sperm is very important in the embryo development. So we assess the quality of the embryo by the development of the embryo, how the embryo divides every day, how it progresses. Say on the first day, embryo is one cell on the day of fertilization. Next day, day 2, the embryo divides to become 2 to 4 cells. And on the third day, it becomes 6 to 8 cells. So it keeps multiplying. That is called the embryo development. And by the 5th day, the embryo becomes what is called blastocyst. It contains a small cavity inside with fluid. That is why it's called blastocyst. Cyst means cavity with fluid, and blastocyst means embryo, and blastomeres. These are the embryo cells. That's why it's called a blastocyst. And they become, at that stage, they have 100 to 120 cells. So you see how the cells have multiplied. Supposing the embryo development is not according to this textbook, and it is slow in development, then we say, well, it's not a very good embryo. Similarly, we look at the morphology, appearance of the embryo, and we grade it. That's what it is called, grading of the embryo. But this is all to certain extent only. And sometimes we say there is a saying which mentions that the appearances are deceptive. And that is very much true with the embryos, because the embryo might look beautiful. Embryologists will say, oh, it's a AA blastocyst, great, top grade. However, we do not know whether it's chromosomally normal inside or not, or what is the genetic content like. That is what is called PGT-A, pre-implantation genetic testing of the embryo. A stands for aneuploidy. What is aneuploidy? It is an abnormality in the number of the chromosomes. Doesn't look at the structure of the chromosome. This is only the number. That's why it's called aneuploidy. So, for example, everyone knows about Down syndrome. What happens in Down syndrome? There is an extra set of chromosome in chromosome 21. Normally, the chromosomes have 2 pairs. that is one from the mother and one from the father, or we can say one from the egg, one from the sperm, and they fuse together and they become one set, that is one pair of the chromosome. So chromosome 21, like any other chromosome, should have 2. Instead, if it has 3, it is called chromosome trisomy. That means it has got 3 arms. Okay, and when it has it in chromosome 21, it is called Down syndrome. That is what it is. It is the variation in the number, not the structure of the chromosome. And that's what we are testing in aneuploidy testing. So that's what we try to see. If there is any extra chromosome or less chromosome in one of the chromosomes, or less chromosome material, I should say, in one of the chromosomes, then that leads to problems and gives rise to Down syndrome or Edwards syndrome or Peteau syndrome. There are so many syndromes like that according to the variation in the number of the chromosomes. And that's how we test for all these things to find out if the chromosome is genetically normal and or chromosomally normal, and it will give rise to a healthy baby. So these are the things as far as the embryo is concerned. And I told you people can have miscarriage and failure of implantation due to other causes, not with the embryo. It is something to do with the implantation side of the story. So what happens in that, the uterus may not be good enough or strong enough, or there could be some other immune factors. So when I say uterus may not be strong enough, the important structure in the uterus is the lining of the uterus, or we call it technically endometrium. So it should be of good thickness and good texture. If this is lacking, then it can lead to problems. And also sometimes the uterine cavity can be interrupted by structures like fibroid or polyp, which gives rise to uneven surfaces and interference with blood supply. That can also cause problem with implantation and lead to miscarriage. That is why we always say before putting the embryo back in, it's better to check the uterine cavity with saline infusion scan. We put saline inside the uterus and do a scan, particularly 3D scan is helpful to see if the cavity is smooth and regular. There is no bumps or ever lumps inside the cavity, which will interfere with implantation. Or if there is any doubt on this investigation, we go ahead with what is called hysteroscopy, putting a camera through the cervix to have a look inside the cavity there, then and there. And if there is a polyp or something, we remove it at that stage. Or if there's a scar tissue in the uterus, that can also be removed, because the scar tissue does not have any blood supply and it can lead to thin lining of the womb, which again can cause miscarriage. That's why it's important to deal with all these issues or problems with the hysteroscopy, which will help with the implantation very much. And supposing the uterus is normal structurally, there is no problem. But there could be other issues like immune factors which can interfere with the implantation. What are immune factors? Now, women have what are called autoimmune diseases and immunological diseases. One of the commonest immunological disease which women of reproductive age have is endometriosis. All of you must have heard of endometriosis. People have cysts in the ovaries. The cysts are filled with blood, and that is chocolate material. And this endometriosis usually is due to antigen-antibody reaction that is called immunological factor. And such women usually have antibodies in their system. What do these antibodies do? They go and kill the eggs or attack the eggs. And that's why women have low number of eggs associated with endometriosis. And they can have similar effect on the embryos. They can attack the embryos and interfere with implantation, interfere with the blood supply to the fetus and cause miscarriage. And these women can also have what are called the natural killer cells and cytokines, which can also cause problems in the uterus. That is why it's important to carry out these tests before putting the embryo back. If there is any issue with the antibodies, natural killer cells, there are specific treatments for this, and we can provide this treatment before starting the embryo transfer so that the embryo will have a good support and good normal immune system to support the implantation rather than immune overdrive, which can affect the embryo implantation. But having said all these things, this immune testing and immune treatment is associated with a lot of controversy, and some people don't believe in that. But I have to say there are no randomized control trials on these things because it is very difficult when somebody is having a miscarriage. We can't divide people into two groups and give treatment for one group and tell the other group we will give you only placebo or something you won't even know. And who will enter such a trial? Everybody wants to have a baby. They don't want to keep on having miscarriage. And I think it's difficult to carry out these randomized control trials in this group of people. And so far, nobody has done it. And that's why it is not evidence-based. We must remember it. Having said this, again, in many clinics and in my clinic, in my personal experience, people have had 3 to 5 IVF treatments before, have had so many embryos transferred, and they have never been successful. They have come to our clinic, and with all this testing and everything, we have made the baby for them in their first attempt. So I will say these people are the living proof for the treatment working very well. Now, choosing the best embryo, Suvir, I would like to hand over the presentation to you.
Okay, thank you very much, Dr. Venkat. So now we move on to the nitty-gritty of this talk. So now you know where embryo selection and the problems that can arise in an embryo fit into the overall picture in having a healthy baby. I'd like to discuss in more detail how we go about choosing the best embryo, because one of the other things is we want a nice single healthy baby. And typically when patients go through an IVF cycle, they might produce quite a few embryos. So how do we choose? So the first thing we can do is we can see how an embryo develops compared to a textbook model. So here you can see over 5 days, starting with the day of egg collection, which we call day 0, where an egg is basically one cell and it's being fertilized with the sperm. Fertilization occurs overnight, and then the embryo has what we call 2 pronuclei. These are small compartments that contain the first copy of all the genetic material from the egg and the sperm. The next step is that one cell divides into 2 and then 4 cells over another period of about 24 hours. So on day 2, so if we say we did egg collection on the morning of day 0, and then on day 2, we would expect the embryo to contain somewhere between 2 and 5 cells. Typically, they will contain about 4 cells. And then the following day, we would have seen another round of cell division, and you should see ideally 8 cells, but somewhere between 6 and 10. And day 4, there's quite a lot of cells, and typically reaches about 64 or so by the stage, but then it reaches the next stage in development is when the cells actually differentiate. So this is when the cells split. They essentially form 2 sort of groups. There's what's called the inner cell mass, which is what you can see in the middle of that little round disc at the blastocyst stage. And that's what goes on to become you. And then there's a ring of cells that you can see around the outside. And those are what we call the trophectoderm cells. And those go on to become the placenta during pregnancy. And below the cartoons, you can see some actual photos of embryo, starting with an egg on day 0, and then that becomes what we call a 2 pronuclear embryo on day 1, and then a 4-cell embryo, and then an 8-cell embryo. Day 4, we tend not to observe the embryo, we give it a bit of peace and quiet. It looks like a bit of a mess, and because it's going through a transition phase to becoming a blastocyst, so the pictures don't really look very good. And then by day 5, it will become a blastocyst, and here on that image below, you can see the inner cell mass and the trophectoderm ring around it. Now, traditionally, we would only look at embryos once a day. So we'd start when they're collected during the egg collection, and then the embryologist would put them away in their dish in the incubator, and then check them every morning, so once a day. And this gives us a snapshot, but it doesn't really tell us what's going on in cell division, because not all embryos behave as a textbook embryo, which I'd like to show you an interesting video. So recently, we've started using a technology called time-lapse microscopy, where we basically take a time-lapse movie of the embryo as it develops while it's in the incubator. So this is great because we don't have to disturb the embryos. We can take a picture of them in their sort of natural habitat in the dish, and observe how they actually develop continuously over time. And so this short movie will show you how an embryo might develop. You see it has 2 cells, and then it becomes 4, but then there's a fifth cell as well. And then it coalesces back as well. So embryos can misbehave. So that gives us a bit of a clue as to which ones are the best. But as Dr. Venkat mentioned earlier, we don't know what that means with regards to their genetic makeup. So, we observe how the embryo looks, whether it looks the right shape, has the right number of cells, if all the cells are quite uniform, and then we can look at when cell division occurs, does it follow the right pattern? So embryos that are more close to the ideal are said to be better quality embryos. But again, they might be great looking embryos that divide quite normally, but they might not have the right number of chromosomes. So all cells in our body should have 23 pairs of chromosomes. We call this number the euploid number for humans. And what we want to know is whether the embryos are actually euploid. What's really interesting is that there's a very high incidence of aneuploid blastocysts. So what we're doing with genetic testing is basically we take a small sample from the embryo and check those cells to see whether or not they have the right number of chromosomes in them. There is, with this process, a very small risk of actually damaging the embryo because you're removing a small sample, but it is less than 1%. And then what we're looking at is how many blastocysts actually had the right number of chromosomes. So, and this graph is the opposite. It shows how many were aneuploid. So if we took 10 embryos, how many of those would have the incorrect number of chromosomes? And what's really interesting is this increases with maternal age. It correlates almost linearly. So, starting at less than 35, number of aneuploid blastocysts about 52%, and it increases to almost 80% by the time the woman reaches 42 and a bit. So what that means is if we look at the converse, by the time someone, a lady is 42, only 1 in 5 of her good-looking blastocysts actually contain the right number of chromosomes. And as Dr. Venkat mentioned earlier, only ones that contain the right number of chromosomes will result in a healthy pregnancy. Now, having 5 blastocysts in someone who's 42 would be spectacular. But even if we do, only 1 of them would actually result in a healthy baby. So that's why testing the embryos is a very powerful tool, because it allows us to find out which embryos are genetically normal or have the right number of chromosomes and would give us the best chances of achieving a pregnancy. Now, I do have to add a caveat to this, which is that pre-implantation genetic testing for aneuploidy is currently viewed as a treatment add-on that's classified red by our regulator, the HSFC, because similar to immune testing, there's lack of a randomized controlled trial for the effect of genetic testing on pregnancy and miscarriage rates specifically. However, there was a randomized controlled trial not too long ago, 3 years ago now, in women aged 38 to 41 that showed much better clinical outcomes. That means better delivery rates, better pregnancy rates in women who had PGT-A compared to those who didn't. And so this is actual data from all of the USA. This is 2016 pregnancy data, and it shows the clear difference in having treatment with pre-implantation genetic testing and without. So the graph on the left-hand side shows live birth rate per egg collection. And the group in pink, all the bars in pink are for the group without PGT-A, and all the bars in blue are for the group with PGT-A. Now, as you can see, the blue bars for each age group are higher than the pink bars, which means that for each age group, having PGT-A will increase your chances of having a live birth for every egg collection that's performed. But what's more interesting, actually, is the second graph. So one problem we have is that when older women have IVF and they have pre-implantation genetic testing, they don't make a lot of embryos. And when we test those embryos, as you saw from the previous graph, there's a very good chance that very few, if any, of the embryos will actually contain the right number of chromosomes. And now there's no sense in transferring embryos that don't have the right number of chromosomes. So unfortunately, if the patient is an older woman and she goes through IVF with PGT-A, there might be no embryos that are actually available for transfer. But it does provide us with the information as to why the treatment is not successful. We know that it's because of the embryos. We're not left wondering what's going on. So that's what the second graph shows. So the second graph shows the live birth rate for patients with and without PGT-A, but now it's shown per embryo transfer. So if we only look at patients who actually have embryo transfer, so what that means typically in the cases without PGT-A is they go through a round of IVF and they'll transfer one embryo back or two. What that means in the cases who have PGT-A, though, is that they will go through an IVF cycle, and the numbers shown only represents the patients who actually had embryos that were suitable for transfer, so patients who had euploid embryos. And if you look at the graph in the blue columns in that second graph, the rates are astonishing. You're seeing an almost 50% rate. There is a bit of a decrease from the under 35 group up to the over 42 group. You're still seeing a well over 40% live birth rate per embryo transfer in women over 42, which is astonishing, because if you compare that to the live birth rate per embryo transfer for women over 42 who don't have PGT-A, that's sitting around 5%. So that's almost a 10-fold difference in the treatment, in the success rate for treatment, which is, to me, it's astonishing that we don't do it in all cases. But there are practical considerations on this. And then the last slide shows how it impacts the miscarriage rate. So, as Dr. Venkat alluded to earlier, one of the most common causes of miscarriage is that the embryo carries the wrong number of chromosomes, so it's aneuploid. And so if you look at the pink columns, you can see across the ages, the rates going up. So the miscarriage rate increases from about just over 10% all the way up to well over 50% in women over 42 when you do IVF without PGT-A. But now if we look at the PGT-A group, yes, there is a slight increase, but the increase goes only from about 10 to about 17 or so %. Now, so if you compare that last group, that's quite astonishing again, because if you don't have PGT-A, or if you don't perform PGT-A in the IVF cycle and you simply transfer the embryos blind, as it were, there's almost a 1 in 2 chance that that will result in a miscarriage. Whereas if you do PGT-A, it drops that by about 2.5-fold. And that's a big difference, because miscarriage is quite a traumatic event to go through. So it's food for thought. And now I'd like to hand back to Dr. Venkat to go through the treatment pathway with you, so what this might actually look like, how it's performed. So thank you very much.
Okay, so now we are back to the reality. This is the real treatment pathway. Once you have decided to proceed with IVF, what happens? First of all, you need to have consultation. Some patients tell me that, oh, doctor, I had consultation in that clinic, so I don't need consultation here. It is not like that, because when you are going to have a treatment in a clinic, that doctor needs to know about you. Only then he or she can plan your treatment. Therefore, it is important for the couple to come to that clinic and have all the investigations in that clinic. Or if they have done recently the scan and blood test, they can bring a report which is complete and clear, and it contains all the necessary information needed for proceeding with the treatment. We can accept it. And if there is any doubt, or if the results are abnormal, we might like to repeat it. And this will all be discussed with initial consultation. You have an initial consultation with the fertility specialist in our clinic. And please, if you have had investigations before, we encourage couples to bring all the reports so that we can go through that and decide which will be useful, which need not be repeated. And basically, the tests involve an ultrasound scan for the woman and hormone profile, that is to check various hormones such as anti-Mullerian hormone, which gives us the ovarian reserve, FSH, LH, and these tell us about the ovarian function and the egg quality and all the other hormones we check. Once we have done that, of course, as I told you before, we should not forget the man. We must do the semen analysis. That is also equally important. And we do that analysis. And then so we have information about both the sides. And after the investigation, the doctor goes through the results with the couple and plan their treatment. First, they discuss the options and see what is the right option. And if it is to have IVF cycle for you, then the doctor will recommend it and go through the process. What are the steps involved, and prepare you for the IVF treatment. There are certain things we'd like to do before you commence your treatment. That is the preparation. So when you come, if people always ask, what is the timeline, doctor, in your clinic? I think this timeline is the reasonable and practical timeline. It will happen in any clinic. I tell you, it's not going to be, it cannot be fast-tracked in any other clinic. There is no shortcut to IVF. We have to go through all these things. So this is the first step, and this is called first cycle. When you come to the clinic, this is what happens, and this is the investigation, diagnosis, and preparation for IVF. Now, next step or the next cycle, we do the the treatment, which involves stimulation. Before we start the stimulation, we usually prime the woman. What do we mean by priming? We give some progesterone tablets in the previous cycle for something like 10 days to make the eggs and the follicles grow together so that we get maximum number of mature eggs, which will be useful, which will only fertilize. Immature eggs will not be useful for us. Therefore, we want to increase your outcome by priming the cycle, and then the woman will have a period. So that is, we come to the second cycle. With the second cycle, we start the hormone injections. People always worry about the injection. They always think IVF is painful because of these injections. These injections are not very painful. This is given under the skin. It's called subcutaneous injection with a fine needle like insulin injection. This can be done by the individual, and the nurses will teach you how to do it, and we have videos and everything. So the woman does it at home, and then during this 10 to 12 days period of hormone injection, the woman needs to attend the clinic 3 or 4 times for an ultrasound scan and blood test for monitoring of her progress. Because we must remember the important complication of IVF, which is mentioned everywhere. If you Google IVF and complication, what is the first complication mentioned? It is called ovarian hyperstimulation syndrome, and the doctors, call OHSS in a stylish way. That is all the simplified form. Or if you forget that term, you can always say overstimulation of the ovaries. What happens is when we give hormone injections, especially in women with polycystic ovaries who have lots of follicles and eggs, they produce lots of eggs. And then we collect the eggs. We collect something like 30 eggs. I have collected 44 eggs in one woman. These people have severe polycystic ovaries. When we give even small dose, they produce lots of eggs. That is called overstimulation. They have some, symptoms like bloating of the tummy, ovaries are enlarged, they start feeling sick, they are not able to eat, so they feel unwell. This kind of symptoms, these are called ovarian hyperstimulation syndrome. To prevent this happening, we need to monitor the woman very carefully and adjust the dose of the hormones accordingly. So at the end of the 12 weeks of this hormone injection, the follicles will be big and they will be ready. The eggs will be ready to come out. So we book the patient for what is called egg retrieval or collection procedure. Again, when we talk about this, women are always frightened because they think that when they take the eggs out, it is going to be extremely painful. We are not in a barbaric century now. So all the procedures, even mild, simple procedures, are carried out under anesthesia. But it is not general anesthesia. It is called intravenous sedation. So there is an anesthetist to look after you. The anesthetist will give intravenous medication, which will make you go to sleep completely. You won't feel any pain. The procedure takes about 15 to 20 minutes. And at the end of it, we'll wake you up. Usually the first question, when we wake the women up, they ask me, "Doctor, when are you going to start the procedure? I am very sleepy." We always tell them, "Look, we have finished it." And they will say, "Oh, I didn't feel a thing." That's how it is, because you are totally asleep. You don't feel anything. You don't have to worry. So we take the eggs out on the day, and the man has to produce the sample. And in the laboratory, we mix the sperm and the egg. Again, here I would like to mention one thing. I know it's not relevant to this talk here. Some people hesitate to do IVF because they say, "Oh, if you just keep everybody's egg, it's like in stores, eggs here, sperm here, anything can mix with anything, mistakes can happen." It is not like that. When you come to IVF clinic, it's always double witnessed by everybody. We also have electronic witnessing system. So if you use somebody else's eggs instead of your egg, the alarm will go off. So the whole world will come to know we have done something wrong. So they will stop the procedure. So there are systems, because we have to maintain a high standard so that such mistakes do not happen. This is very, very important point, because it's somebody's life here. Therefore, we'll take all the precautions and we mix the eggs and the sperm. That is called IVF. That is, we put them together in a dish in the laboratory and put it in the incubator. Next morning, the embryologist will come and check and see how many have fertilized. Okay. And then, like we mentioned before, Suvir mentioned, went through all the steps of the embryo development. We grow the embryos. That is, after, you can see in the slide, after collecting the eggs mixed with the sperm, then the embryo development happens. And here, we always recommend testing the embryos for reasons which we have mentioned to you. It is very important. The aim is not just to have a baby. We have to change our words. We have to say, "I would like to have a healthy baby." That is most important. And we must also remember, nowadays, our regulator, Human Fertilization and Embryology Authority, is recommending the clinicians and the patients to have one embryo at a time. They say, even if you have 3 embryos, don't put 2 embryos together. We all think that everybody who comes to my clinic says, "Doctor, can I have twins? Will you put 2 embryos?" Yes, it looks nice when they are pushing a pram with 2 babies. They look so cute. They look similar. They're dressed up nicely. But having twins is not simple. It can lead to complications during pregnancy for the mother as well as for the babies. And throughout life, it is not a simple work. It's hard, such a hard work. And I mean, that is a discussion by itself. I won't go into it. So the regulator, that is the Human Fertilization and Embryology Authority, always recommends us to transfer 1 embryo. And they want us to keep the multiple pregnancy rate or live birth up under 10%, because this twin pregnancy leads to complications. That is the reason they are saying it. And if I have to put embryo into any patient, if I transfer embryos blindly, I'm not doing the right thing for the patient. Like I said, there is a risk of embryo not implanting if it's abnormal, or it will give rise to miscarriage, and only rarely they end up with healthy babies. That is the reason previously people were transferring 2 embryos and 3 embryos, because we were transferring embryos blindly. But now we have a method to test the embryo. So supposing you have 3 embryos, all 3 may not be normal. Only 1 may be normal, 2 may be normal. So if I put the wrong embryo, which is abnormal, I am wasting your time and money. What am I doing? I'm asking you to have a frozen embryo treatment, putting the wrong embryo. So you have a miscarriage. That's waste of time and money. So you have to come back to use the second embryo. We don't know whether that is normal or not. Again, same thing happens. So third embryo happens to be the normal embryo and it gives you a baby. This is a waste of time and effort, and it's, make people get depressed because they have negative cycle. So it is better to transfer the right embryo. That is the word, not a good embryo. It is the right embryo. What is the right embryo? Right embryo is a good embryo which is chromosomally normal, or it contains the right number of chromosomes. That is the one which is going to give you a baby and a healthy baby. That's what we do. And that's why if you are going to test the embryo, you can't have fresh transfer in the same cycle because it takes about 10 days to get the results of the test. So we have to freeze the embryo. And the research has shown recently that it is better to transfer the embryos in the next cycle because during the stimulation, like I mentioned just now, women usually have 10 to 15 eggs, their tummy is bloated, ovaries are enlarged, hormones are high, she is not at all well, and the body is not in a fit state to accept the embryos. So that's not the right time to put the embryo back and make her pregnant. It is better to make her rest and recover from this stimulation and transfer the embryo in the next cycle. That way, her chances of getting pregnant are much better. So recent research says that it's better to transfer embryos in the second month, that is the following month, not in the same cycle as fresh embryos. Basically, what we are doing nowadays is dividing IVF into 2 stages. Do the hard part first, then recover from that, and next month you come quietly and put the embryo back in. Meanwhile, the embryos are also tested. Then we can choose the right embryo, put it in, and the result, you have a beautiful baby. So that's what we are trying to do. So this is the second IVF. Second cycle is the IVF cycle. And then, like I said, look, they develop the embryo here, and then embryo biopsy and freezing of the embryo. They send it to the genetic lab. Or they don't send the whole embryo. Don't get confused, because the embryo is frozen, kept in our lab. We take 1 or 2 cells from each embryo and send those cells in a test tube to the genetic laboratory for testing. So the embryos are numbered, so we know which embryo is normal or abnormal when they send the result. So I told you the treatment pathway. We have done the first cycle is investigation and preparation, and second cycle is the stimulation phase, and third cycle is the transfer of the embryo, third month. So the embryos have been tested. We know which embryo we are going to transfer. And now, since we all say it's better to transfer 1 embryo, you want the right embryo to go in, then we can select the right embryo. And the preparation is for the embryo transfer is not at all difficult. Unlike the first stage, where the woman has to have injections every day, here we do tablets for 10 days or so. That is the estrogen tablet. This is the hormone produced by the body. But before that, we give 1 injection before her period starts to suppress all her body hormones so that they don't interfere with our treatment. And then we sort of give the hormone tablets and look at the lining of the womb, how it has developed. And when it has reached a good size and texture, like I mentioned before, then we start with the progesterone hormone in the form of an injection, and then we decide about the date of the embryo transfer and put the embryo back in. And because the embryo is already grown to 5 days, your test date will be quicker. Previously, we were testing after 14 days. Now we test after 10 days. It's not a long wait. I know it's still a very long wait for you when you're expecting something to happen every day. You want to know whether the treatment has worked or not. So after 10 days, we do the test to see if the treatment has worked or not. And this is the third cycle you have then completed. And hopefully with the tested embryo and transferred, we covered everything. It's a beautiful embryo. We have put it in and the treatment is successful. That leads to the 4th cycle, which is the positive pregnancy test. And then we do an ultrasound scan in 3 weeks' time to check how the baby is developing. It's in the right place in the uterus. It is viable with a heartbeat and everything. And that fourth cycle is the longest cycle, I have to say, in life, because it takes 9 months to make that baby grow and develop inside the womb and then deliver. And that is the joy of your life. That is, of course, I say the main point here is healthy baby. That is the one which is going to make you very happy. And remember, that's why it's important to do PGT-A. What is it? Pre-implantation genetic testing for aneuploidy. If you forget that word or difficult to pronounce, you can say for abnormality. So we are testing for chromosomal abnormality to choose the right embryo to give us a healthy baby. That is the whole story. It's so simple. So now I will have to hand over to my dearest colleague, Carina, for further information. She will be your point of contact. Over to Carina.
Thanks, Dr. Venkat. Good evening, everyone. So I'm one of the patient coordinators. I may have spoken to some of you already, but what I wanted to start off with is, so we do have further information available. So do please check out our website, as well as our genetics lab websites on the links below. And we did also have a Instagram live recording where our embryologist Sam discusses 5 things you need to know about embryos. So it's definitely worth having a look. And also, if you have a look on our website, if you have any questions at all, please just let us know. We're available over telephone or email. I always tell patients, if I don't have the answer myself, I will find out for you, and we will always get back to you. On to practical steps. So the first thing, if you haven't already had done so, is to have a checkup. That's the first step on this journey. So as you may already know, all non-physical consultations are currently being done remotely over telephone or Zoom, but the clinic is open and we are operating as usual. So you are able to attend the clinic for any tests or procedures that are required. And also we do currently have our full female fertility checkup package on offer at the moment. And this includes the consultation, the full hormone profile blood test and the scan, plus a follow-up to discuss the results and next steps. So if this is something that you're interested in, please do get in touch with me and I'll be happy to discuss this further with you. And lastly, I'd like to just leave you with the final message, just to say, please do consider PGT-A to shorten your time to pregnancy.
I will turn it over to the audience for any questions and answers. So there should be a question and answer functionality in your sort of dashboard. So you can send us any questions that you might have and we will try and field them for you. So we've had one through already. And the first question is, for women over 40, if PGT-A is performed, would it give guarantee of a healthy baby, or should any other additional tests be done in order to try and minimize the risk of not having a healthy baby? I'm going to hand this over to Dr. Venkat because it's more a clinical question of antenatal care and so on.
Right. Thank you for this question. It is an important question, actually, clinically. Yes, the first step is to do PGS because we want a chromosomally normal baby, and we do that. But having said that, there could be other issues as well. Like women do develop fibroids in their womb over the age of 35. The incidence of fibroid is over 20% after the age of 35. Therefore, it's important to check the uterus. That is, I told you, it's the bed for the baby, to see if there is any problem with the uterus. And if there is fibroid or polyp, we should deal with it first, especially if it's projecting into the cavity. We should deal with it, remove it, make the cavity smooth before putting the embryo. And in that video, like we saw, if there is a damaged tube, it's better to remove the tube or clip the tube. Particularly if some woman has an ectopic pregnancy on one side, the tube is likely to be damaged on the other side as well. So if you clip it, because the risk of recurrence of ectopic is very high in such a woman, even by IVF, you might think that in IVF, we are putting the embryo into the uterus. How can it go back to the tube? It is still possible. and the embryo can go back into the fallopian tube and get implanted there, especially if it is a damaged tube. Therefore, we say that it's better to clip the tube before you proceed with another treatment. That's why I advise that young girl to have the tube clipped because she had one tube removed by the ectopic and she had the other tube. Told her, go and get it clipped. Otherwise, there is a possibility of the embryo going back into your other tube and causing another ectopic pregnancy. So if there is some problem with the tube or fluid collection in the tube, it's better to clip the tube so that the embryo doesn't migrate back into the tubes, and that will prevent ectopic pregnancy. And other important thing which happens over the age of 38 and 40 is all these changes in the body, like immune issues, which I mentioned earlier. I don't want to go through the whole thing again. You can develop antibodies, clotting issues. Therefore, there will be a higher tendency to form blood clots in the placenta, which will interfere with the blood supply to the baby. And anybody can have natural killer cells and the toxins produced by the natural killer cells, which can interfere with implantation or cause miscarriage. So these are important in women over the age of 40, and it's important to get these things tested. So you prepare yourself well for the treatment, because like she said, sometimes people don't do these things. When we say it in the first round, they say, oh, no, I am a healthy person. My family didn't have any problems. So I don't think I want to do all that, doctor. Let me just do the IVF. And then things go wrong. And then finally, we spend more money in the treatments. Instead, if you invest in testing the embryo and other things, you're more likely to get pregnant. So if you're over 40, it's better to rule out all the other aspects which can interfere with implantation so that the outcome is successful in the first attempt if possible, or as soon as possible, to maximize your chances for a successful outcome. Thank you.
If I might just ask you to comment also a little bit more on, the continued need for antenatal testing, because PGT-A couldn't make you stop it.
Yeah, okay. So PGT-A is it's a good test and accurate test. Yes, it's right, but it is never 100%. Any test is not 100% in this world. We must remember that. There is always the possibility of some false positive and other things in PGT-A. Remember, we are testing the placental cells. We are taking biopsy not from the inner cell mass, which is going to become the baby. Because there are two questions people always ask. One is, when you do the biopsy, take a cell for the testing, do you damage the baby? No, we don't damage the baby, because we are not taking cell from the tissue or the cells which are going to develop into the fetus or the baby. We are not touching those. We are only touching the outer layer of cells which are going to become the placenta. But remember, these cells came from this originally same cells. They are not different cells starting from the beginning. Therefore, testing the placental cells, which should give the result for the baby fetal cells as well. That is the principle based on which we do the embryo testing. But sometimes there could be different chromosome numbers in different cells. That's called mosaicism. There's a small possibility these things can happen. And that is why they say that it is never 100%. It is important to have the antenatal testing, but you don't need to go, if someone is 42, you don't need to go for antenatal testing such as amniocentesis or chorion-villus biopsy sampling, CVS it's called. But we can go for the non-invasive prenatal testing. It's called the NIPT. There are so many of them, Harmony and Panorama and so many things. We can do one of them, where we do a scan to confirm the viability of the baby. And then we take some blood sample, which will check the cell-free DNA from the maternal blood and tell you whether the baby's chromosomes are normal or not. So this is the confirmatory test. Because most patients think that, oh, I have had a PGS or PGT-A, there is no need for me to do it. I think it is better to do it and confirm it in some ways. It will be helpful so that you are reassured that everything is okay with the baby now. Thank you.
Thank you. And actually, one last point on that same note. You should also have antenatal screening because embryos can still develop genetic abnormalities or chromosomal abnormalities as they grow. It's not something that's always fixed in stone because these abnormalities can crop up every time a cell divides. So as the embryo, we test it at one point in time, but even subsequently there might be an issue that arises. So yes, you should have all the testing done. The next question that we have is, hi, can we transfer frozen embryos that we have in a different clinic in London to have the test done in embryo transfer at your clinic? Yes, you can quite easily transfer the frozen embryos to our clinic. That's not a problem. Our lab will liaise with the lab at the other clinic and move the embryos across for you with a specialist courier. Now, this brings up a good point. Can you have PGT-A if the embryos have already been frozen? The short answer is yes, but the long answer is it's not the ideal route because in order to perform PGT-A, as mentioned, you have to take a small sample from the embryo. And in order to do that, you have to thaw out the embryo. And once you have taken that sample, we have to freeze the embryo while we wait for the results. So if you have frozen embryos, we would need to thaw them out, biopsy them, and then refreeze them. So that puts the embryo through a bit of stress because we're getting it out of its natural way. We're unfreezing it. We're putting it through a mechanical process. So it's not ideal, but it can be done. And it is something we have done for quite a few of our patients. And it works quite well, but it's not as good as doing it the first time. The next question we have is, are frozen 3A, B, and 3BB embryos good enough? Well, this comes back to the first point that we discussed, which is that, these are embryo grades for any of you who aren't quite sure. Those are sort of middling embryos. They're not top grade embryos, but that's not the whole picture because it doesn't tell you what the genetic makeup might be. And you heard, from the patient's story, actually the embryos that were genetically normal weren't the greatest looking embryos. So, the sort of morphology or the grading of the embryos only tells us so much information. So, yes, they could be good enough, but they're not necessarily the best looking embryos. Sorry if that's not a very clear answer, but that's the best we can give you. Can a woman over 42 have a healthy and successful pregnancy? I will give you the short answer of yes, but I will hand it to Dr. Venkat. She has anything to add.
Sorry, what is the question, Suvir?
Can a woman over 42 have a healthy and successful pregnancy?
Oh, why not? And I will say positively, yes, it is possible. I am a very optimistic person in life, so it can happen. But truly and scientifically, I am saying that it is possible. And that is why we say we emphasize on this PGT-A, which will be useful. We have recently, I think people in my clinic are aware of this case. I'm not exaggerating. This is a true case report in our clinic. We haven't released it because she hasn't delivered the baby yet. I'm waiting for her to deliver. This is a 48-year-old woman. She came to us and she came to me for a consultation and told me, doctor, we want to have a baby, all this history I took and everything. Because she was 48, I sort of had the feeling that, okay, she's thinking about donor eggs, obviously. Her eggs are not going to be good and everything. So I told her, look, are you thinking of donor eggs and would you like me to arrange a donor egg treatment or what are you thinking of? Because I have no idea. She said, no, doctor, I got married only 2 years ago. We got married late and we want to have a baby with my own eggs. That's what we are here for. And she was very naive and simple. She didn't understand much about science and all those things, I have to tell you. And I told her, look, at your age, you remember, you are 48. It is going to be very difficult. And even if you get pregnant, it can be abnormal, miscarriage and all those things. She said, no, I want to try with my own eggs. She said, I'm willing to do whatever you tell me. So I told her, look, in that case, we will check your fertility, ovarian reserve. To my surprise, her AMH was 28. I remember all these things. Even if you ask me in my sleep, I can tell you, because these are very unusual cases. I remember everything. And then because it was 28, I told her, look, I will give you a chance to try with your own eggs because you have got an exceptionally high ovarian reserve. Let's go for it. But only thing I will sort of request you to do is testing the embryos, because at your age, you will be making a lot of chromosomally abnormal embryo. If I transfer them, you are not going to get pregnant with a healthy baby. So it's important you test the embryo. She said, okay, I will do that because you said it is important. So she did it. And you won't believe, I'm telling you, she produced 22 eggs and 14 eggs fertilized. And she had at the end 8 blastocysts. At the age of 48, she had 8 blastocysts. And we biopsied all 8 blastocysts. And finally, what did she have? She had 1 chromosomally normal embryo. I was thanking God, saying, oh, at least she has got 1. But this lady came to me and said, doctor, I have only 1. Do you think I will get pregnant? I said, I am so happy you have got 1 normal embryo. Let's put it in. And we put it in, and she's pregnant. Now she's 30 weeks pregnant. Touch wood, everything is going well with her. And in fact, she doesn't know how lucky she is. I'm telling you, at the age of 48, to have a healthy baby at the first attempt, that is another thing you must remember. She didn't have 3 attempts or 5 attempts. She had 1 attempt, and she's pregnant in the first attempt at the age of 48 with her own eggs. This is a very unusual case. And so when 48-year-old woman can have this, why can't a 42-year-old have a healthy baby and healthy pregnancy and everything? I will say a definite yes to that question.
Excellent, thank you. The next question is, my husband has severe sperm challenges. Can IVF be successful, and what can be done to improve chances?
Yes, of course, now we have a lot of treatments for these sperm challenges. If the sperm count is low, motility is low, we have advanced forms of IVF. We say IVF, it includes a spectrum of treatments, actually. IVF is artificial, in vitro fertilization. That is fertilization happening outside the body. That's what it means. But the fertilization method can be different. So we just mix the sperm and the egg, it is standard IVF. But if the sperm count is low, or they are not moving well, or some other issues with the sperm, we inject the sperm into the egg. That is called ICSI, or intracytoplasmic sperm injection. And if somebody's sperm has got a lot of abnormal forms, a lot of abnormalities, then it is difficult to choose the right sperm to inject. Then we use a more powerful microscope to select the sperm. That is called morphologically selected sperm, or IMSI, IMSI, to select the sperm for injecting the sperm into it. And supposing there is no sperm coming out from the man, there are methods by which the sperm can be surgically retrieved from the testicles or epididymis and used for treatment in the form of ICSI to fertilize the egg and make a baby. And these are all possible. There is a lot of development in this male fertility nowadays. And so anything is possible. If there is a male issue, please seek help, and definitely any clinic can help you.
Thank you. Those are all the questions that we have had. Okay, we have not had any other questions come through. So with that, I would like to, first of all, thank you all for attending. I hope that this evening's webinar was useful. And then I'd like to thank our panel. So thank you, Dr. Venkat. Thank you, Carina. And last but not least, I would like to thank our moderators. Thank you very much, Ashley and Claire. And I would like to wish you all a very good weekend and bid you good night.
Thank you.